Well, good evening and welcome, everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Bruckville, and I will be serving as your program facilitator and will present your questions to our panel of experts. This evening, Jefferson Health experts in neurosurgery, physical medicine, and rehabilitation will answer your questions about spine care. Well, thank you so much for submitting your questions in advance. The questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. And if you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital guidelines and privacy, we are unable to comment on specific cases. Well, with that, I want to go ahead and introduce our experts for the evening. And this includes Dr. Kyle Matthias with neurosurgery, Dr. Jason Burke with physical medicine and rehabilitation, and Jennifer Malone with neurosurgery. Well, thank you all so much for joining us. I know we have a lot of questions to get to tonight, but first, if each of you could just introduce yourself, say hello, provide a little background information about yourself, that would be great. And then we'll get into our discussion for tonight. So Dr. Matias, we will go ahead and start with you.
All right. Good evening, everyone. It's a pleasure to be here. My name is Kai Matias. I'm a neurosurgeon. I'm specialized in spine surgery and also in functional neurosurgery, which involves stimulation for chronic pain conditions. I've been at Jefferson for about 8 years now, including my fellowships and as a faculty.
Okay, great. Well, welcome. We're excited to have you. Okay, Dr. Burke.
Hey guys, how you doing? My name is Jason Burke. Thanks for joining us tonight. It's good to be here. I am a physical medicine and rehabilitation specialist, but I subspecialize in kind of musculoskeletal medicine and spine care. I'm from Philadelphia. I did my residency at Jefferson, and recently returned home back to Philadelphia and joined Jefferson this year. So I'm happy to be back and looking forward to talking with you guys about spine care.
All right, we're happy to have you. Thank you. All right, and last but not least, Jennifer Malone, how are you?
Hi, fine, thanks. Thanks for having me. My name's Jen. I'm a nurse practitioner. The majority of my career has been spent taking care of patients with neurologic conditions, specifically neurosurgical patients, and in that, specifically patients with spine conditions. Most of my career has been at Jefferson, 25 years of a career. Most of it's spent at Jefferson. I also have a good amount of experience with inpatient palliative care and 3 years spent working as a nurse practitioner in an acute rehab hospital with our PM&R folks, our physiatrists. But back to neurosurgery full time, and I work with our spine surgeons at Jefferson.
Okay. All right. Well, thank you all. With that, I think we should just go ahead and dive into the questions. I know we received a ton, and then we will get to the live questions at the end. So I will turn to Dr. Matias to kick us off. First question for the evening. When does a spine condition require surgical intervention?
Okay, yeah, that's a very good question. To make easier to understand, we can split into two major conditions. The first one is when it involves the spinal cord, and the second one when it involves the nerves. Whenever there's compression of a neurostructure, they're at risk, especially if it's a spinal cord. So that's one of the situations where we need to think about surgery right away. Not in emergent setting, but surgery has to be in our minds. When it comes to the nerves, they can usually accept a little bit more longer time of compression. So when the nerves are involved, usually, unless there's weakness, usually we tend to be spend more time on the conservative management before thinking about surgery.
Okay. All right. Thank you. Okay. Next question here, Dr. Burke. What are the most effective non-surgical treatments for chronic neck and back pain?
It's also a really good question. And because there are so many non-operative, non-surgical treatments for chronic back pain. The tried and true and like the top three modalities that I would say would be physical therapy and diligence with a physical therapy provided home exercise program. Number two, physical therapy and diligence with a home exercise program. And number three is physical therapy with diligence with a home exercise program. Physical therapy is of utmost importance, and it's not just going to physical therapy. It's getting the exercise program and taking it and doing it independently on your own and doing it indefinitely. It's a lifelong commitment to managing your back, your spine, and your core. Other things that are super important in terms of effective non-operative care for neck and back pain, lifestyle and activity modification. So these would be things like, weight management, which again is not a quick fix, but it's a long-term goal and maintenance program. Adhering to good posture and good lifting mechanics where you're, using your legs and not focusing on your back to lift things. Modifying how you do your physical activities throughout a given day, learning ways to work around activities and mechanisms that tend to aggravate your pain. And you work through these things with your physical therapist. And then really like focusing in on what I call like the gray area, choosing exercises and modalities of physical fitness that don't put undue stress on the back and the neck. But very rarely do I tell anybody with back or neck pain that they can't do something that they enjoy doing. Rather, it's again finding that happy medium, that gray area of modifying the way you do the exercise, or maybe the intensity or frequency with which you do an exercise that might, cause more strain and stress on the back or the neck, and then supplementing those off days with things that are less strenuous on the back.
Okay. All right. I think biggest takeaway, follow your PT plan. So
Yes, big one.
all right. Thank you. Okay, Jen, we'll turn to you. What medications or non-opioid options are available when standard pain relievers are ineffective?
Okay. So standard pain relievers, assuming we're talking about the traditional over-the-counter analgesics like aspirin, Tylenol, Advil, Motrin, that kind of thing. If we're calling that standard non-opioid. So in the category of non-opioid medications, this sort of space of medications that exists between our over-the-counter stuff and our prescription opioids, there are things like prescription NSAIDs like Toradol or Celebrex, Ketorolac, oral steroids, prednisone, dexamethasone, that kind of thing. There are topical agents like lidocaine patches and gels, capsaicin creams, Voltaren gel, which is a non-steroidal topical agent. Sometimes you will hear one of us talk about a medication like Neurontin, gabapentin, or Lyrica, pregabalin, which falls interestingly, into the category of anticonvulsants. And that's always a very interesting conversation to have and to explain. Other times we'll use in the category of antidepressants, not because we're going after depression, although pain actually can contribute to depression frequently, but we'll use medications like Cymbalta or Elavil to help with pain. We also use muscle relaxers sometimes that's indicated to help. So things like Flexeril or Zanaflex or Scalaxin. I don't know as much about the sodium channel blocker medications, but there are some out there that our pain management physicians are using. I don't know what insurance covers, like this could be one of the medications that's a little harder to get covered. Also a good conversation to have with pain management. A lot of patients will utilize medical marijuana to help with pain. That's not an opioid and not a standard, over-the-counter pain medication. And then other things that don't get a lot of attention or haven't lately are compounded medications. So there are compounding pharmacists and specialty pharmacies where they will take a lot of these non-opioid medications and compound them into, gels or creams or capsules. So, these are some of the things that we'll talk about with patients that fall into the world of non-opioid pain medication.
Okay. All right. Thank you. Good to know that there's a lot of options. So appreciate you walking us through that. All right, Dr. Matias, we will turn back to you here. Question for you. What are the surgical options for severe cervical or lumbar nerve compression?
Yeah. So there's a major difference between the cervical and the lumbar spine. The spine is designed to support our body and also to protect the spinal cord and the nerves. So the spinal cord brings the information to and from the brain to the rest of the body, right? So at the level of the cervical spine, you have spinal cord. In thoracic spine, spinal cord. At the top of the lumbar spine, you don't have spinal cord anymore, you have nerves. So the major difference between cervical and lumbar is the neurological structure it protects. Uh, when we're talking about compression at the cervical spine level, we're talking about spinal cord compression, which is more it's a little bit more urgent because the consequences of delayed decompression of the cervical spine uh, can be catastrophic. So whenever it comes to the cervical spine, uh, one of the options is to decompress the nerve structure, usually from the back or from the front, depending on each case. Because that can cause instability of the spine by removing some parts of the spine. It typically involves also something called fusion, which basically is using a hardware like screws and rods or plates to hold the bones together and let them then fuse, then bring calcifications together so it doesn't move, being stable. That's for the cervical spine. When it comes to the lumbar, we have the nerves, and they can take compression much more than the spinal cord. And that's when, even though they might be severely compressed, if there's no loss of function, meaning weakness, we can insist or exhaust other options like medications, like physical therapy, like certain types of injections. However, if someone is experiencing weakness, for example, a foot drop, that's one of the situations that the nerve needs to be decompressed. For example, a herniated disc. We need to go there and remove that herniated part of the disc. Or older patients where the spine canal over time got more narrow, causing something called stenosis. We do a procedure where we shave part of the bone, remove the thickened ligament, creating extra space. So those are the two main scenarios where decompression is needed for the cervical spine and for the lumbar spine.
Okay. All right. Thank you so much. Okay, before we turn to our next question, just a friendly reminder, as we're going through our questions right now, if anything's popping up for you, feel free to drop it into the Q&A and we will get to that at the end here. But for now, we'll continue with our submitted questions. So Dr. Burke, I will turn to you. What rehabilitation strategies help improve function in daily activities affected by back pain?
Yeah, so that's kind of a loaded, kind of very broad question because there's so many different kinds of physical therapy programs that can be employed for any person with back pain. And you got to keep in mind that not everybody's back pain is from the same cause. There's different causes for back pain, whether it's disc herniations, like that were just noted. Sometimes you can have arthritis in the back that's causing the back pain. Sometimes it's muscular problems causing your back pain. Sometimes it's not even the muscles or the spine itself. Sometimes it's joints that are just below the bony spine, kind of in the buttock area, called the sacroiliac joint. So there's lots of different causes of back pain. So the most important part when you're developing rehab strategies and rehab programs is identifying what you're trying to treat. And that's where, seeing a specialist is very important to work with you to kind of hear what kind of pain you're experiencing, to do a very thorough exam and to, devise a likely differential diagnosis as to where we think your pain is coming from. And once we have that idea in mind, we then can, devise a physical therapy program. And in general, a lot of the strategies when it comes to dealing with back pain are strategies that work on strengthening the core. So the core muscles are those that kind of engulf and envelop the spine, so they kind of act like stabilizers to help stabilize the back and the spine when you're doing your day-to-day activities. Also, work is done on loosening muscles, not only in the back, but also muscles that are in the pelvis and in the hips. Because if muscles around the spine and the back are tight, it changes your mechanics when you walk and your posture mechanics, and that can lend itself to back pain as well. Along those lines, working on posture mechanics, very important, and also lifting mechanics, very important in a physical therapy program, because we want to optimize people's lifting mechanics and their just general mechanical posture. Because as was mentioned before, your back and your spine kind of act as the scaffolding, the support mechanism for your body. And bad mechanics, bad posture can lend to unnecessary strains and stresses on the back that then can produce as pain from muscle or disc or from joints in your back. So that's a very super important component of any physical therapy program that is done. And additionally, what's really helpful during focused, directed physical therapy is working with the physical therapist on the types of activities that you do in your day-to-day life or at work, so they can be replicated with the physical therapist, so that they can observe and see how you are doing these programs or these activities, so that modifications can be made if the mechanics are being done in an improper fashion that's lending itself to the experience of back pain. So a lot of the goals of physical therapy are to really optimize not only your form, but also your function in how you do your day-to-day things. And like I mentioned before, the most important part about a physical therapy or a rehab program is not necessarily just the work you do when you go in to the physical therapist. A lot of people get concerned about physical therapy because they say, look, it's not going to work for me. I don't have the time to commit, 2 times a week for, 6 weeks. Those times when you're in the physical therapist's office aren't the important times. The important times are when you transition those programs and those tips and tricks to the real world and at home, and you maintain consistency with a home exercise program. That's what gives you the longevity of the therapeutic benefits from the rehab program.
Okay. All right. Thank you. Yep. And definitely a reminder to go see your provider and talk to your provider more. So thank you. Okay. All right. Jennifer, what are the next steps when treatments like injections or radiofrequency ablation do not relieve symptoms?
Yeah, so I think when you say injections or radiofrequency ablation, I'm assuming that also sort of encompasses the other types of injections that our interventional pain management colleagues can implement, like medial branch blocks or trigger point injections or facet blocks. So, I'm not an interventional pain management specialist, but we all work very closely with them. So we have a good idea of some of the other techniques and tools that they have at their disposal. And they actually have quite a bit. And there are some things that sort of exist between injections and spine surgery. The ones that I'm familiar with are mostly targeted towards lumbar spine conditions. And I won't go into great detail, but some of our patients who are listening who may have an interventional pain management specialist and are dealing with back pain issues may hear things like the mild procedure or Vertiflex or Intracept or something called Viadisc. So they sort of exist in that space between injections and sort of full-blown surgery. After that, it kind of depends on what the problem is. And if there is a clear kind of cut indication for surgery, meaning your symptoms, your exam, and your images sort of all line up to show us that, yes, you've exhausted these non-operative treatments, maybe you've had some relief, maybe that relief is wearing off, and we can offer you a decompression or a decompression infusion and feeling fairly confident that will be successful, then we have a conversation like that about surgery. If your symptoms persist and your imaging is not entirely convincing, and it's not that we don't believe that you're living what you're living, we're just not certain that as a surgical practice, offering you a surgery is going to, at the end of the day, address your symptom, then we might have conversations about pursuing things like spinal cord stimulation therapy, and rarely, but it does happen, intrathecal drug delivery systems for addressing your pain, in that means. And that's, there are select medications that can be delivered via a pump and catheter into your cerebral spinal fluid. And that in itself can be a whole other webinar, but that's essentially, where we are when we talk about next steps.
Okay.
Do you mind if I just jump in for a quick second? So in a prior life, I was an interventional spine doc. I did a fellowship in interventional spine. Jennifer's exactly correct. And this kind of goes to the point of it's very important when you're even talking about interventions before you even get to that point of getting an idea of where your back pain is coming from, because each of the interventions targets different things. I see lots of patients that come in to see me that say, I tried the injections and they didn't work for me. But not all injections are equal. So each of the interventions targets a different source or a different cause for back pain. There are injections or interventions that are specific for disc-related pain. There are separate injections for arthritis pain from the back. There are different injections for pinched nerves or sciatica in the back, and yet other injections for other joints of your back. So there's a whole gamut of interventions or injections. So what's important in this process is not just getting an injection, it's, making sure that we have a good, and again, seeing your specialist and having a good, clear idea of where we think the pain is coming from to ensure that the injection that are being tried uh, are the correct ones for where your pain is coming from. And the nice thing about injections, I'll just quickly add this, is that they also, it's, to some extent, serve a diagnostic purpose, meaning that if there is some gray area where you might have pain coming from maybe arthritis in the back, but maybe also from a disc problem, sometimes an injection can help solve that question. Where if they do the injection that's designed for the arthritis problem and you get better, well, that cleared up more definitively where the pain is coming from. And from the surgeon standpoint, again, if there's a question of whether or not your pain is coming from a pinched nerve going down the leg, and you get the injection for a pinched nerve pain and you get relief from it, that further clarifies to other specialists that yes, this is in fact where your pain is coming from. So I think the takeaway from what I'm trying to say is that not all injections for back are the same. There are a whole gamut of them, and it really takes just having an idea of that we're treating the correct thing to know if the injection that you got done was correct or the right one or beneficial or not. So,
All right. Thank you. I think that's helpful for people listening. So appreciate you adding that on. Okay. Continuing along here, Dr. Matthias, we'll get back to you. Can you explain the process involved in the spinal cord stimulation procedure?
Yes, of course. So the spinal cord stimulator, it's something that works for a specific type of pain called neuropathic pain. It's almost like the nerves are sending abnormal signals to the brain, saying there's pain all the time, it's a constant pain. And what the stimulator does, it acts as a pacemaker, but for the spinal cord. So it's going to mess up and confuse those signals, stopping them from going up all the way to the brain. So it masks the painful signals going up. Um, the way it's done, it involves a surgical procedure where electrodes are implanted inside the spine canal in close contact to the spinal cord, where the stimulation is going to be delivered. The first stage is called a trial, where the leads are or electrodes are externalized, connected to an external battery. The patients go home. It's very comfortable. They don't have pain from that, other than some soreness from the procedure. And then they try different settings of stimulation, and they can feel what to expect from the stimulation and if the stimulation is going to help with their pain. If they have benefit, they have improvement, then the second stage involves implanting a permanent system where everything is going to be internalized, electrodes and a small battery that's going to be everything underneath the skin. Everything's going to be internalized. So that's the second procedure. And over time, we can adjust using a programmer the settings inside the stimulator, trying to address different types of pain, different areas of pain, uh, so that the patient can experience the maximum relief possible.
Okay. All right. Thank you so much. All right. Now, turning to Dr. Beck, let's talk a little bit about alternative therapies. So, are these alternative therapies, maybe such as acupuncture or chiropractic care, are they helpful and recommended to relieve back pain?
Yeah, it's a good question, and the general answer is yes. Uh, my typical approach to treating somebody with chronic back or neck pain is that uh, it usually isn't one treatment, one conservative treatment, one surgical treatment, one interventional treatment that is the solution. Uh, Typically, it is doing a program of things and taking a little bit out of each bucket. Uh, each treatment kind of targets the pain from a different perspective and the cause of your pain from a different perspective. So acupuncture, not a lot of literature out there that really defines how it works, but I can tell you that I have patients upon patients upon patients that swear by it. Uh, and when you think about like, a treatment for any condition, you want to weigh risks and benefits. And something like acupuncture, I mean, it has the potential to give great benefit and it has very, very low risks. So if you have that kind of treatment option where there's a high chance that you could get some relief and very low chance that you're going to have any kind of negative outcome, it's worth trying. Chiropractic care for me is a little different, um, depending upon what we're trying to treat. Chiropractors, I think, when you think about chiropractors, you think about like, quick, snapping of the neck and quick like readjustments, and that's not really what current chiropractics are. If you with a good chiropractor, um, they do more than just alignment work. They also do a lot of soft tissue work, a lot of muscle myofascial release work, which again can be a very large component of neck and back pain. When it does come to like adjustments of the spine that chiropractors do, I am more comfortable of that being an option for low back pain. I typically am not as comfortable with it for neck pain because, as Dr. Matthias had noted before, in the neck, your spinal cord is still there, but not only that, your vasculature to your brain is there. So not all chiropractors are made equally. And I have had patients that have had complications after chiropractic adjustments when they were dealing with cervical spine or neck related issues. So I tend to stay away from chiropractic manipulations, like manipulating the spine when it comes to the neck or cervical spine, and tend to focus more on like the myofascial muscle techniques and releases that a lot of chiropractors do for that.
Okay. Yeah, absolutely. Thank you. I think that's helpful for everyone listening. So appreciate those call outs. Okay, Jennifer, we will turn to you if you're still there. Um, Jennifer, are you here? Otherwise, I can move to the next person. She may have had to step away. Okay, we'll go to Dr. Matthias and then we'll get back to Jennifer when she's able to return. Oh, we may have had some issues. Hi, Jennifer. Can you hear us?
I can hear you. Can you hear me?
We can. All good. Okay, perfect. Great timing because we are just about to move on from your question, but I'll go ahead and ask you.
Okay. Sorry about that. I'm back. Don't know what happened.
No worries. Zoom likes to be fun and kick people out for random reasons.
That's how you know we're live. This is not recorded.
Exactly.
We're live here.
Not at all.
Exactly.
No.
Okay, Jennifer, question for you here.
Ah.
What activities should be avoided during the early recovery period after spinal cord? Oh, sorry. Let's see here. Yeah. What activities should be avoided during the early recovery period after spinal cord stimulator implantation?
Okay. So after spinal cord stim has gone in, what you need to understand, and you probably may, is that those electrodes that your surgeon implanted and placed oh so carefully in the perfect position is being held in with sutures. And that electrode needs some time to settle down and scar into place and to stay put. So, um, you know, things like, well, just in terms of incision care, of course, we want you to bathe, but we don't want you submerged in water, submerged in bathtubs, pools, oceans, that kind of thing. So we need that incision to close up. But we also don't want you doing anything strenuous. We don't really want you lifting anything more than 5 to 10 pounds. We don't want you stretching up and overhead and reaching. We don't really want you twisting. So things like playing tennis or pickle or golf, not a good idea in the weeks, after spinal cord stim. Um, maybe not pushing a vacuum cleaner, reaching in and out of a dryer. Like you can do these things with some modifications or some help if you have it. But anything we do, you kind of want to keep your spine sort of neutral and in alignment. Walking or very, very light type of exercise is fine. Other things we talk about is driving. So until you have a really good sense for how that stim feels and how it's responding, it's been a little bit since I've taken care of spinal cord stim patients specifically, but I recall that there was you could have one setting for when you were lying down and another for when you were sitting and another for when you were walking. And so, trying to figure out how that feels, you might not want to be behind the wheel of a car because if you suddenly have a different kind of stimulation and that's startling, you certainly don't want to be, operating a car. Um, those are the big ones. Dr. Mateus, I don't know if I'm missing anything, kind of big.
No,
If
no,
I
you're
have, please jump
exactly
in.
you covered basically everything.
Okay.
It's very important that highlight that stimulation is about location, and we spend a good amount of time in the OR trying to find the perfect spot. And if the leads move, then we lose that. We need to come back for a revision. So it's very important the first few weeks until the leads are healed in place that we have those restrictions. But after restrictions are lifted, then it's back to a normal life.
Okay. All right. And this next question for you, Dr. Matias, I think is a nice follow-up. What are the potential risks or side effects associated with spinal cord stimulation?
Yeah, we can divide into two types of risks, the surgical risk and the stimulation risk. It's a surgical procedure, so always involves some sort of risk for infection, risk for hemorrhage because we implant in the leads with needles. Uh, um, but the risk for infection and hemorrhage is very small. There's a potential risk for nerve damage or even spinal cord damage because we're going to be very close, but everything is done under sedation or anesthesia. We have X-rays, live X-rays, telling us where exactly the leads are going. So it's a very safe procedure, although those kind of risks exist, infection, hemorrhage, or some sort of nerve damage. Um, Regarding the stimulation risks, after the stimulation, the stimulator is turned on, there are different types of stimulation you can provide to a patient. One type, you're providing sort of like a buzzing sensation or a tingling sensation, and the idea is to replace the pain with that buzzing. Some patients they love that because they know the stimulus is working. Some patients they hate that. So there's a second mode which we call quiet mode. The stimulation is on, but you don't feel it. So with both types, especially with the tingling mode, if for example if you cough or if you lay down, if you sneeze, the spinal cord will go a little bit closer, and you can feel this zapping down your legs. But now we have newer devices that they can auto-regulate. If the electrodes they go closer to the spinal cord, they can detect in a matter of a fraction of a millisecond, and auto adjust it so you don't have that zapping.
Okay. All right. Thank you. Okay, Jennifer, we'll go back to you here for this next question. How is chronic neck or back pain diagnosed when imaging appears normal?
Okay. Well, how is it diagnosed? I mean, if you're living with chronic neck pain or chronic back pain and that is your experience, I mean, we're going to believe you, right? Like, we don't necessarily need to have radiographic evidence for us to say, like, this is your thing and this is the thing you're living with. But there are a lot of times that we meet patients and we put up their MRI or their CT or their X-rays, and it's it's not as it doesn't demonstrate necessarily the degree of symptoms that they feel, right? So, sometimes we will take a closer look. For instance, a CAT scan, like if a patient doesn't have a CAT scan and they have a lot of pain, an MRI or even a traditional X-ray could miss a fracture, right? It could miss a congenital abnormality that it's just not getting picked up on that scan. So we'll look a little further. Um, Sometimes when we see, somebody with degenerative disease in their lumbar spine and they have a lot of back pain, and they don't have a dynamic X-ray, we'll send them for a dynamic X-ray, which is, you stand up, so it's a weight-bearing view, and you bend forward into flexion and extend back. And if we see any malalignment or instability through that movement, now we've got a little bit more information about your back pain. Okay. Um, Other times, we will use things like upright MRIs. So people will say, look, I'm fine if I'm lying down. My problem is when I'm standing or walking, bearing weight, because traditional MRIs are taken with you lying down, right? So we don't necessarily see, the degree of maybe, disc compression or something. So we'll order an upright weight-bearing MRI, or rarely we'll order something like a cervical MRI with flexion and extension views. So the MRI techs have a way of, kind of bolstering your neck up to bend your neck forward in an MRI and then to kind of drop your head back and take pictures that way. Another study that we've started to use a lot more of lately is a study called a SPECT CT scan. And that helps us, we use it as a way to try to help us identify a pain generator. And it's basically a PET scan technology merged with a CAT scan technology. And what it's looking for is essentially osteoblastic activities. So where there's a lot of bony turnover and potentially inflammation. And it's not, we don't solely use this study as to completely guide us, but it helps give us a little bit more information. So if you have somebody who has bad degenerative disease at every single level of their neck, and you really cannot figure out like exactly where this neck pain is coming from, and you send them for a SPECT CT and this come back and it's lighting up, in the facet joints of C5-6 or at the end plate of C3-4 or something like that, like that can help us. And what we usually do with that is it helps us guide a little bit more treatment options back to our interventional pain management doctors. Like maybe we'll ask them to zone in on this one specific level. And when that happens, if a patient has a good response from that, again, as a surgical practice, that gives us some more idea. Like Dr. Burke was saying, it's not just therapeutic, it's diagnostic, and it can help us sort of narrow down like maybe what we're focusing on for surgery. So those are some of the other diagnostic tools that we can look at when maybe more traditional things aren't giving us, all the information.
Okay, very helpful. Thank you. All right, Dr. Matias, we will get back to you here. One more question on spinal cord stimulation before we move on, and then I know we'll be getting back to our live audience questions shortly. But for now, how effective is spinal cord stimulation in reducing that long-term pain for patients?
So patients always ask about a number. What's the number? What's the percentage of reduction, right? Pain is very subjective. So for some patients, if they have a pain that's 5 out of 10, it's extremely painful. And some patients, they can, be in a 7 and say, yeah, I'm fine with that. But overall, the number we're looking for is at least 50% pain reduction. So if the pain was rated as an 8, they should expect to drop it to a 4. There are some patients we see in the literature and we see in our, daily practice that they experience even a little bit more, sometimes 60% pain reduction, sometimes even 70%. So what I tell my patients is, okay, let's talk about the number, but also let's focus on other things like what's your goal? Oh, my goal is to be able to walk around the block with my dog. My goal is to be able to stand watching my grandson's game. So we focus on, are you able to achieve that goal during the stimulation trial or even with the permanent? How's your quality of life? Do you have, are you able to do more of your hobbies? Are you sleeping better? Do you feel that you're happier now? Can you do more things? Can you work more hours? Can you spend more time outside with your family? So that's what I try to focus on that because I think that gives us a better, a more concrete perception of the amount of improvement or the degree of improvement. But in terms of numbers, we should expect roughly about 50% pain reduction.
Okay, great. Thank you. And I think that's a helpful mindset when thinking about it in terms of goal setting. So appreciate you talking us through that. Okay, Dr. Burke, question for you here. What signs or symptoms during recovery should prompt a patient to contact their doctor?
Yeah, so like Dr. Matias had said, like spinal cord stimulator placement is a surgical procedure. So much like similarly with any kind of injection, anytime you notice that the surgical site is looking red or any kind of drainage from it, if you're feeling feverish or feeling ill, getting chills. Those are always indications that you should contact your physician immediately, as Dr. Matias had noted that, the main risks with any kind of medical procedure, infection is one of them. So you want to make sure that is ruled out if you were to experience those things. Other times you would want to contact your physician would be if you notice any worsening pain after the stimulator is placed, any kind of new weakness. Those would be like the big kind of overarching indicators. Dr. Matias, are there any others that you would kind of highlight?
No, I think you covered everything. Yep.
Okay, perfect. All right, Jennifer, we'll turn to you for this last question before we get to our live questions from the audience. What warning signs indicate that spine or nerve pain may worsen and need urgent evaluation?
Warning signs of spine or nerve pain may worsen. So, I mean, I think, honestly, if your pain is escalating, right? Like, so you're used to your regular type of back pain, your regular type of sciatica, and that's getting worse, or you used to be able to stand for half an hour, now you can only stand for 10 minutes, or you could walk for a mile and you can only walk a block now, right? Like, these are things that we would like to know about, and they're important to us. And we know that pain is debilitating, it's affecting your life, and we care about that and we can take a look at that and work it up. The things that really prompt urgent evaluations, the things that get our attention, um, it's not so much the pain. It's if you're developing weakness. Now you're developing imbalance, changes in your gait. You're dropping things. Your coordination's changing. Buttoning buttons, tying shoes, that kind of thing. Like you're dropping things out of your hands. Um, Another thing is, numbness, we don't usually get too excited about unless it's numbness in your what we call your saddle region. So your buttocks, your genitals, your groin, right? And especially if that numbness is accompanied with changes in your bowel and bladder function, right? So these are the things that, these prompt urgent evaluations outside of if you're a post-op patient, because we just talked about the things that we want to know about after surgery. But like if you're somebody that we're following in the practice and we know you have a problem, yes, we want to know that your pain is getting worse, but it's these other things that really, we start really tuning into and needing to figure it out and get you in and get you looked at or direct you to an emergency room or whatever the case may be.
Okay. Thank you. Important call outs. All right. Well, with that, I want to get to our live questions. I know that the audience has been submitting some, so thank you. How this works, I'll run through them. Whoever wants to respond, feel free. This is definitely a discussion. So, multiple people can respond. We'll have a conversation. So with that, I'll go ahead and ask the live question for tonight. This person says, sitting at a desk causes stress on my neck. What can I do to help elevate neck strain?
So I think that's not uncommon. That's very common. The world has turned into very sedentary kind of work. And then since COVID, a lot of people are now have the luxury of working from home. And it sounds great until we started seeing kind of what you're describing, that with all this work from home, there's a lot of desk work and a lot of, neck strain from posture at neck. And the big things are uh, ergonomics, ergonomics, ergonomics. So I always, when I see patients in the office with similar issues, I pull up quickly online and show them you can Google ergonomic setup for your desk, and it can literally show you kind of how you should be set up in a way that makes the environment of sitting at your desk as optimal as possible, not only for your neck, but for your low back as well. Some jobs, now that so many people are working remotely, will allow through their HR departments home ergonomic assessments of the home workstation, like they used to do when you were in the office. They would have somebody come to the office. Some employers do provide that. Um, the third thing that I think is also super, super helpful is getting a sit-stand desk set up. Never is it advised for the neck or the low back to be sitting for 8 hours, through a workday. So by having a sit-stand desk, whether it's the desk itself that actually raises or comes down, or they do make tabletop or desktop um, um, risers for your computer and stuff. It's always of benefit to be changing your position when you're doing desk work, taking time standing, stretching, taking time sitting. It's changing those positions, taking time stretching, and really focusing in on the ergonomics and having those kind of optimized as best as you can. And for the sit stand desk stuff, like you can find them everywhere now. IKEA has, very manageable kind of desks that come up, and there's all kinds of things online. Um, so yeah.
Yep, I can echo that. I just got a sit stand desk and it's been a game changer. So highly recommend.
Yeah. As Dr. Burke was talking about the ergonomics, I was trying to adjust
Yes.
myself to my computer to my height. Yeah.
Same. I'm looking at myself adjusting.
Yeah.
Yes. So thank you for those reminders. We're keeping them in mind. Okay, next question here. Is there any way to diagnose back pain without imaging? What is the best imaging? MRI, CT scan, X-ray? Any thoughts?
I think I'll start with that one. Um, there's some of the physical exam and the description of the symptoms is I would say is the most important part. We always start with that. What the imaging studies they will do, X-rays, MRI, they're going to confirm or rule out something that we thought while we were doing the exam and taking the history. Um, so of course you can, okay, I think the pain is coming from this facet joint, or no, this is sciatica pain. So my hypothesis is that there's a herniated disc, for example. What the imaging will do is confirm that and will help us decide what's the best treatment option to start with. Sometimes you don't need the imaging right away. You can start with some medications or some therapy exercises, but depending on the how long the patients are experiencing those symptoms, we're definitely going to need some sort of imaging to decide what's the best next step.
And just to add on to that, something I always make sure that I stress to my patients is that we've actually done studies, not me, but people that preceded me, where they actually took people off of the street. They recruited people that never had a history of back pain, never had a history of neck pain, and did MRIs of their spines. And the majority of people that they imaged had abnormal findings on their MRI studies, but they'd never had neck or back pain. So, what that tells us as physicians is you can have things on your MRI. You can have degenerative discs, or you can have a disc herniation, or you can have arthritis. And just because it's there doesn't mean that it's causing you pain. It could just be there, but it's just that we're seeing it now because we got the MRI. So, to Dr. Mateus's point, the most important part of the workup is that encounter with your specialist and the physical exam and the history that you kind of convey to us so that we have an idea of what we're looking for on the imaging to see if it confirms what our suspected diagnosis is based on your history and your symptoms and your exam findings.
Okay. All right. Thank you for adding that on. Interesting research. Okay. Next question here. This person says, what exercises, lifestyle changes, or treatments can fix or improve forward head position or humpback?
I think that's kind of my world. So,
Yeah, definitely. I was like, I'm just like tossing it right to you, Dr. Burke.
So, a lot of that is going to be postural work with a physical therapist, and it's not just strengthening the muscles in the neck or like kind of that upper, we feel that bony prominence in the lower part of your neck. It's also working on strengthening the muscles around your scapula, the shoulder blades, because those are the muscles that pull you back up. A lot of people ask me all the time about, back posture braces and things like that. Braces are great for short spurts of use for when you're doing an activity that in that moment might cause more pain or might cause injury. But I'm not a big proponent of throwing on a brace to improve your posture and walking around with it all day long, because then you're never using the muscles we need you to strengthen to improve that posture, to improve that forward kind of shoulder rolled kind of position. You're just using an accessory device to do the job of the muscles for you. And in that process, weakening them further. So you're actually kind of uh, worsening the issue. So the answer to your question is it's physical therapy, exercise, 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 and being diligent with a program that's specifically aimed at working on posture mechanics and core postural strengthening.
Okay. Yeah, that's an interesting point about the brace. I wouldn't have thought about it that way. So thank you. All right, next question here. We'll get through a few more and then we'll soon wrap up for the evening. Unfortunately, we're almost out of time. This hour flew by. Next question. Can you expand on the interventional treatments available? For example, different types of injections and the quasi-surgical options mentioned, and what they're used to treat?
Okay, I'll take a stab at this. The quasi-surgical, I really hope that I'm not going to embarrass our interventional pain management specialist, and Dr. Burke, please jump in. Um, so we learned this actually, I've learned it from our patients who have gone out and had these things done, and and maybe they come back a year or two later and their pain has returned for whatever reason, or they come to us and let us know that their pain management doctor is talking about these things. So something, for instance, like their Vertiflex procedure can be effective for lumbar spinal stenosis. And I think of it in my mind like a little car jack. Like they take this little device and they put it between the spinous processes and they sort of jack up that space with the hope of sort of opening up the foramen where the nerves come out to give that nerve, more room to live in. And in my mind, I feel like that would be most useful if you knew that your stenosis was really kind of specific to one level, one set of nerves, and that kind of thing. Um, Something like the Intercept procedure, it's in my mind, I think of it like almost like radiofrequency ablation, but to a very specific nerve that goes into, the vertebral body, and it's helpful for specific back pain, back pain specific to sort of one area. And they're basically trying to burn that nerve and interrupt the pain signals that are sort of traveling back and forth in that spot. Um, and then like something like Viadisc is, I understand it to be an injection. They take a synthetic material and almost the way that like kyphoplasty is used to bolster up a bone that's been fractured. They put this material into the disc to kind of plump it up and rehydrate it, and again, sort of like elevate that disc and see if they could address the pain from something very discogenic back pain. Um, and those are just some examples of some of those procedures. And also, I'm trying to do my best answering these other questions that are coming in on the side, in case you guys are wondering what I'm doing here, real close to the computer with my glasses on.
Thank you. We
So
appreciate
just to add in from my background, so I was getting a model of the spine here, just real quick. So there are injections that can be done specifically for the joints of the back. So those would be things like a nerve block, specifically that blocks the nerve that would be causing arthritis pain. And then sometimes if that is positive, like you get good relief from that, then they can burn that nerve away, and that would give longer term relief for pain coming from arthritis in the spine. Then there's other injections that are for if like a nerve is pinched, like kind of here, or if you have a disc herniation and it's pinching the actual nerve and you're getting pain down the leg or sciatica. That would be an injection where they do an epidural, which is similar to like what a woman gets when she's in labor. The difference being that the kind of medicine that's being used and that they use steroid for the pain type of epidural, and they do it under an X-ray machine, like a lot of these injections, and they put the needle kind of in the space where the nerve lives. And you don't inject the nerve, you inject around where the nerve lives. And that's why they need to use the X-ray so they can see the needle's getting where it needs to go. Um, in terms of what Jennifer's talking about, in terms of the Intracept procedure, that would be an injection that's done if you're having pain that we think is coming from a disc pain that's causing inflammation around the bones around the disc. And so you're getting a lot of pain that we think is coming from the inflammation in those bones. They can do an injection where they actually put a needle into the bony area of the spine and also burn that nerve away. So the idea being that if that nerve isn't there anymore to communicate to your brain that there's pain coming from this spot, then you won't have the sensation of pain as severely anymore. But these are not the nerves, just the if this question's out there, these are not the nerves that go down your legs that give you strength in your legs. These nerves are only for these areas for pain sensation when we're talking about these kind of procedures.
Okay. All right. Well, thank you. That was helpful. I appreciate you grabbing that model. That was helpful for me to see at least. Okay. Well, with that, I'm going to ask the final question this evening, which is my own question, just as we are wrapping up. So for the final question this evening, what are your goals for everyone listening in on this webinar? What would you like our viewers to take away from tonight? Dr. Matthias, I will go ahead and start with you.
Yeah, so I think the take-home message I would like everyone to, get from this is there are several options when it comes to spine problems, right? And surgery is just one of the options, one of the treatment options. It involves a multitude of treatments that we discussed today. Uh, Surgery meaning spine decompression is an option, spinal fusion is an option, or even a spinal cord stimulator is an option. But we have to be mindful that sometimes it's not just one medication or one treatment, it's a combination of multiple things. I think that's the most important message that I'd like to send to all the attendees.
Okay, great. Thank you so much. All right. And Dr. Burke?
Well, Dr. Matthias just literally stole my thunder as if he read my little notes that I had here. But no, I totally agree. I think a big takeaway for tonight is that when it comes to chronic back or neck pain, rarely is it coming from one source. By the time it becomes a chronic issue, it may have started as one thing in particular, but over time, other things can then start contributing to the back or neck pain as well. Rarely is it just I have arthritis. Usually it's a combination of maybe some arthritis, maybe some degenerated disc, maybe some compensatory muscle pain. So because back pain is not simple as one thing, then to Dr. Matias's point, rarely is it one thing that's going to address the pain. So, I tell my patients that, there really isn't, I try to stay away from the word treatment when it comes to chronic neck or back pain. I prefer the term management because that's what it is. It's a long-term, multimodal management program that encapsulates a lot of different specialists and specialties and modalities from physical therapy, doing your home exercises, lifestyle and activity modifications, the weight loss, the good core strengthening, the good lifting mechanics, using bracing in times where you might be doing more activity than normal to protect your neck or your back or your posture, medication management and alternative care to help with pain in those moments where it's a little bit more severe than normal, injections, when again, for a pain alleviating procedure, when you're also doing all the other things that we're talking about. I always tell people the injections and the interventions are not standalone. They're part of the pie. And it's doing all of these things. And all of these things that we talk about for back and neck pain, they're not monumental recommendations. A lot of people probably know these things. But when you do them all and you're consistent with them, they add up to a big thing. And I can use myself as an example. I hurt my back when I was in high school. I lost the strength down my leg. I never got surgery. But to this day, I still do my home exercises every day. And if I get to the end of a week, like if I go on vacation and my schedule changes, my back pain, I can feel it. It starts creeping up. So the goal of doing these things, it's a long-term management program. It's usually not a quick fix. It's usually a lifelong kind of endeavor that is a lot of times self-directed. But it involves multiple specialists and a team of specialists like we have here at Jefferson. So it usually involves somebody like me that does conservative management and somebody like Dr. Matthias who does, spinal cord stimulators and interventions, and our pain management team and other surgeons. So it's a group effort. And so that would be my take home.
Okay. Thank you. And thank you for sharing that personal anecdote. I think that will resonate with some of our audience. So appreciate that. Okay. And last but not least, Jennifer.
I think, I just want you to know that, we hear you, we see you every day in clinic, every week. We know that you're living with this. We know that it affects you. We know that, for some of you, it's years and years and years of this. For others, it's acute. We are trying to do our best to do right by you. We are trying to keep you out of the operating room, even though that's how we make our livings. We are trying to keep you out of surgery. So the process can be frustrating and long when you're trying to get your pain treated effectively enough. I think, the things that Dr. Burke spoke about, I usually sum that up with just a term that I call spine hygiene or neck hygiene, however you want to talk about it. And it is sort of a multimodal approach. You have to take control of it, and you have to dedicate yourself to the things that you can do to keep yourself out of our office and out of the OR. And the last thing I would say to everybody is please get nicotine out of your life in all forms. People don't understand how caustic nicotine is to the spine specifically. And this is not a lecture about lung cancer and COPD and lung related issues, although that is terrible. But nicotine in any form, gum, patch, chew, smoke, vape, it's super, super bad for your discs and your back in general, which could be its own webinar. So please just get it out of your life. And anyway, that's a lot. I'm going to get off my soapbox. We're here for you. We do our best to try to help you.
Thank you. And I think a lot of topics covered today probably could warrant their own webinar. So appreciate you finishing with that closing remark. Thank you. Okay, so thank you, Dr. Matthias, Dr. Burke, and Jennifer for your time this evening. Such great information was shared. I know I learned a ton. And thank you all for submitting your questions, for taking the time to attend. We apologize that we weren't able to get to every question tonight, but we will be posting an event survey so you can let us know your thoughts. Are there any other specialties that you would like to hear from? If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out the last question in the event survey. A recording of this event will be sent to you so you can rewatch at your convenience. And if there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening. Good night.